So here's a presentation on seizures. This is part of the paramedic program in EMS 270 Lesson D, and also applicable to EMT level folks, even though there's some ALS stuff in it. So what is a seizure, or what causes seizures? Well, they're not totally sure what causes seizures. What we do know is that it's abnormal neuroactivity in the brain. Maybe that's because the neuronal connections are not wired in correctly. There was a congenital defect that's causing them. It could be also something to do with the neurotransmitter. So the wiring's right, but the signals aren't being transmitted correctly. So the causes are unclear, but regardless, what we end up with is a fairly common thing for us to deal with. Roughly 1 in 100 people in the United States have seizures. Most of those, the vast majority, are controlled, well controlled with meds, as long as the patient stays on their meds, and there's some other treatments out there. Some things that cause seizures could be a rapidly rising fever, could be related to eclampsia and a pregnancy problem, could be hypoxia, could be hypoglycemia, could be secondary to a traumatic head injury, could be drugs and alcohol, could be lots of things. And so while you're dealing with a seizure patient, it's important to realize that we may not figure out why they had the seizure, but there are some quick things that we can go through to check on. First-time seizures, it might just be that their seizure disorder, their epilepsy, the congenital problem, or a neurotransmitter problem. It could be that it's regular seizures and they have just started and you happen to be there for the first one. Could be that it's something more sinister, some sort of neurocrisis, or something that we can easily rule out, like hypoxia and hypoglycemia. But regardless, first-time seizures are a big deal and need to be transported. Febrile seizures are related to a fever. It's pretty common. 1 in 25 kids, usually the younger guys, 6 months to 5 years typically. This doesn't mean that the kid's going to have a seizure disorder or epilepsy, but 70% of the time it's one and done. They don't have a second one. 30% of them will have a second febrile seizure. So if they've had them before, they can have them again. The cause of the fever is the big deal. Usually it's just an ear infection, some sort of upper respiratory infection. It's not a big deal, but it certainly could be. Could be meningitis, could be some neurocatastrophe going on. And it's related to the rapidly rising temperature. And most of them do have a temp that's 102, 103 or higher, but it's the rapid rise of the fever. And so typically these are going to occur on that first day. And so the caregivers may not be particularly clued in to how sick the kid is, because the kid spikes a temp in a hurry and then ends up with a febrile seizure. The care of the child with febrile seizures after the seizure is the same as if it's a seizure from another cause. Seizures can also happen during pregnancy. A person who is preeclamptic has symptoms such as elevated blood pressure, general swelling and edema, headaches, they're spilling protein in their urine. Typically there's some visual problems, visual disturbances, or maybe temporary loss of vision. And a pregnant woman can have any or all of these, and that's preeclampsia. So preeclampsia is that you have the signs of preeclampsia, but you have not had a seizure. Once the patient has a seizure, that becomes eclamptic. So this is a big deal for mom. It's a big deal for baby. It's an emergency C-section. And this, again, doesn't mean that mom's going to have seizure disorders after the delivery. It's probably related to some sort of immune response, although they really don't know. Seizures are fairly mysterious, including eclamptic seizures. For us, if a patient is pregnant and they are having a seizure, we're going to first assume that it is related to the pregnancy and go down that route. It is possible that it's something else, but we're going to go with the most likely and most emergent, and we're going to act like this is a hurry up and go sort of thing, early notification to the hospital for an emergency C-section. We're going to continue to rule out other issues, hypoxia, hypoglycemia, elevated temp, all those things. And then the little tidbit here that to me is not intuitive is that I would have thought that once the patient has delivered the baby, that now the cause of the eclampsia is gone. But as it turns out, a mom that's postpartum, up to a month in some cases, maybe longer, that's having seizures, that can still be related to the pregnancy. And so they are eclamptic seizures even after birth. And we'll talk more about this when we do OB stuff, but I wanted to at least drop that hint in here. So they've changed the way that seizures are classified and some of the nomenclature that's used. And so, and medical professionals, particularly field folks, are still kind of transitioning over to that. And so I don't want you to get too hung up on it, but we do want you to know what is the current standard for naming seizures and how they classify them. And I like this chart where we have seizures are either partial or they're generalized. And on the partial side, you can have simple versus complex. The difference there being the complex ones have some altered level of consciousness. Not altered mental status, they're all altered mental status. But in the complex seizure, complex partial seizure, the patient has a little bit of altered level of consciousness, maybe only for a few seconds. On the simple ones, they typically have an aura. And an aura means that they are experiencing some sort of sensory input that's not real. They see, hear, smell, feel things that are not real. And this can be maybe hard to detect, and you don't always have to have an aura with other seizures, but we wanted to introduce the term aura and make sure everybody was clear on that. So that's a key point, and that'll show up in your assignment. Generalized seizures, full body seizures, and there's several terms there for you as well. A person is termed to be atonic when they are weak, limp, collapsed. When they're in the tonic phase of a seizure, they're stiff all over. The clonic phase is the jerking that typically you would associate with a seizure. So a person that's having tonic-clonic activity is initially stiffening and then is having alternating periods of jerking and stiffening, and that's the tonic-clonic phase. The older term grand mal seizure is still used in a lot of places, and it's still fairly common field jargon. But technically we're talking about tonic-clonic generalized seizures. An absent seizure used to be called petit mal, and those are not involving generalized tonic-clonic seizure activity. There's just a kind of a spaced out, glassy-eyed, staring off, just not here for a little bit, sort of piece to that. And then the term myoclonus or myoclonic activity is jerking and twitching. That may not, it's not specifically the full body stiffening of the tonic piece, and it's not the full body jerking of the clonic phase. This is myoclonus or jerks and twitches. So several terms for you to be familiar with there. They show up on your assignment and will show up in literature that you read, textbook passages that you read, and probably the National Registry exam. What can be done for prevention of seizures? Because the treatment really during the seizure is pretty difficult to do anything other than to try to protect the patient. And then we can try to stop seizures with benzodiazepines like midazolam and diazepam and lorazepam, the benzodiazepines. But preventing the seizure is a whole lot better deal than trying to suppress it and treat it. There's a whole list of meds I'll show you in a minute that patients may take for seizure prevention. There are some new innovations called a vagal nerve stimulator. We'll talk about that briefly, and in your resource document, there's a pretty decent video from a patient who has one of those, and she actually activates it during the video. And then there may be surgical intervention if they can isolate a cause in a location. Here's that whole list of meds. Now, one of the first things to know is that several of these meds are really usually only prescribed for seizures, but several of these meds are prescribed for several things. So if your patient is taking gabapentin, Neurontin, that could be for migraine prevention, it could be for nerve pain, and it could also be for seizure prevention. Same with Topamax and Tegretol. And then, so it's important to gather a patient's med list. It's important to recognize these medications are used for seizures, but it's also important to not be under the assumption that if a patient's taking one of these meds, it must be because they've had a seizure disorder. As you can see, there's a whole list of them. They typically come with significant costs. They come with significant side effects. And many of these meds are pretty much dulling the neuronal activity in the brain. And so patients experience a fuzziness or a foggy mentation, and they have a hard time concentrating. But the risk of having a seizure while driving or working is a big deal. And so there's this trade-off where these folks are having to decide, am I better off with the side effects of the med, or are they just as bad or worse than having the seizure? And so for those reasons, patients, both the cost and the side effects, sometimes patients stop taking their meds. And I would say, at least in our local system here, and every place I've worked, the most common reason for us to go to a patient having a seizure is that they have a known seizure disorder and they stop taking their meds for some reason. That's the most common. Here's the vagal nerve stimulator. Nobody really knows how this works. They just know that it does. It's surgically implanted. The thing's about like a pacemaker, a little bit smaller, and stimulates the vagus nerve. And they can use a magnet that they wave over it to activate it. And again, do watch the video in the resource document. She does an excellent job of explaining what goes on with her. And it really is, I think, interesting to watch her activate the device and see the impact it has on her and the change in her voice and everything afterwards. So the idea here is that it would allow patients to use a lower dose or fewer anti-seizure meds and thus avoid the costs and avoid the side effects. It probably reduces the frequency of seizures. It probably doesn't terminate the seizure. It probably doesn't stop them from occurring. But anyway, I want you to know that those are out there and get a feel for what the scar might look like. Sometimes your patient, when you see your patient, they will be altered level of consciousness and altered mental status for an unknown reason. And one of the reasons to do a history and physical, the physical, would be to look for these sorts of things. Maybe there's a scar, maybe there's evidence of the device being placed, maybe the patient has bitten their tongue or their lip, they have some oral trauma, maybe they have urinary incontinence, and certainly those things don't guarantee that it was a seizure. Oral trauma and urinary incontinence don't guarantee it was a seizure, but they certainly make you suspect that. Also, the absence of those doesn't rule out a seizure. So it's important to be clear on these things. Yes, those are hints in your physical exam, but they're not absolute. Big, scary, true emergency is status epilepticus. Those are multiple seizures that are back-to-back without a return to normalcy. Or one really long seizure, and generally we're talking 5 minutes or more. Now, when you go to a seizure call and you'll say, how long was he seizing? The person that called, the bystander, the family, will typically overestimate that. So I usually follow up with, okay, I don't argue with them or tell them that their perception of time is wrong. I just say, okay, tell me what you had time to do while he was still seizing. We ran a call recently here locally where the gentleman who's well known to us, and we know him, and he's a straight shooter and very sincere. But this patient, his wife, had never had a seizure before. And I asked him how long the seizure lasted. He said 10 minutes. And then I said, so what did you have time to do in that time? And he said, I called 911, and she was still seizing that whole time. And then I said, so how long before the first responders walked in the door did she stop? And he said a couple of minutes. Well, they were out the door with the dispatch and had like a 2-minute response time. So clearly this seizure didn't last 10 minutes, probably more likely 3. And this is from a very engaged caregiver, good historian, and it was easy for him to overestimate. So I don't think that you can walk in the door and know that it's status epilepticus, for sure, unless you do a little deeper investigation. Certainly, if that patient has a seizure and you're called, and then they have another seizure in your presence, unless they came fully back to normal before that second seizure, that's looking like status. Status is a big deal. The problem is that while they're seizing, they're not ventilating and oxygenating, and so they get a little hypoxic, and that's assuming the seizure wasn't caused by hypoxia, but let's just say it wasn't. So they were normal oxygen levels, then they seized, then they have this period where they aren't ventilating, they aren't oxygenating, and then the seizure stops, and that's when they recover and get back to normal and get their O2 levels back up. If they go ahead and seize again, then we have this progressive hypoxia. The causes can be tumors, it can be traumas, but it's less likely that these are epileptic seizures. So statistically, not always, but more often than not, a patient that's having real status, back-to-back or continuous very long seizure, that's not a regular seizure disorder. That's something big and more scary. A brain tumor, head trauma, some kind of neurocatastrophe. Our care is the same. We rule out hypoxia, we rule out hypoglycemia, we rule out hyperthermia. So, and we get some vascular access and stop the seizure with an appropriate dose of benzos. And I keep saying vascular access, but remember, the benzos can also be given intranasally. It's just that seizure patients are snotting and snorting, and it's very difficult to get decent absorption in many cases there. But you do what you got to do. It's incredibly difficult to start an IV on a seizing patient. It is less difficult, although still a pain, to try to get seizure meds in intranasally. So that's an option during the seizure. Best case is you get an IV in after one seizure and before the next one, and you're ready with your benzos if it happens again. So here's some considerations. Almost done here. Here's some considerations for you. Most ambulance services have their benzodiazepines in the controlled medications secured storage, which is in the truck. It's not in your first in bag. And so unless you are right next to your ambulance, you can walk out the front door, run to the truck and get your narcs, your narc box. It would make a great deal of sense to bring those in. If you're going to have to go through a long-term care facility where you have a long pathway down and around several hallways, or if you're going up an elevator or just don't have immediate access, you're going to need to bring your narcs with you. When you bring your narcs in the house, keep your eyes, and better than that, keep your hands on your narcs. Don't forget them and leave them, because you don't have any backup in the truck, and they might be of interest to folks once you leave. Make sure you have an IV site that won't be compromised. If you start an IV on a patient in their AC space, and then they seize, and they have the clonic activity with the significant contractions, it's likely that your IV won't be patent. So you're looking for a forearm site, something that's not going to be compromised. A wrist is a bad idea, and an AC is a bad idea. Try to get something in a seizure-proof spot. And secure that IV. Normally a VenaGuard is what you would use, or tape or something like that. In this case, you need to secure this thing as if they're going to have another seizure and it's going to be easily ripped out. And again, first-time seizures are a big, hairy deal, and you ought to get going to the hospital and realize that those may be from some sort of catastrophic thing going on. Always, always rule out hypoxia, rule out hyperthermia, check their glucose, check that BP, probably in that order, actually. And always, always check these things out. Takeaway points: protect that patient. Don't try to restrain them. Try to keep them from banging their head. Try to keep them from falling. But if they're on the ground or on a bed during the seizure, don't try to stop the seizure. Don't ever go in their mouth, even if they're biting their tongue. It's very, very hard to watch. If they're biting their tongue or biting their lip, you're not going to make any progress trying to pry their jaws open or something crazy. So protect them and wait until the seizure stops. Then you've got airway and breathing to deal with, and then your investigation starts. Hypoxia, hypoglycemia, hyperthermia. And on those febrile patients, if they are warm, cool them carefully. We don't want to put them into a shivering state, but you need to unbundle them, uncover their head. Typically, they're the little guys. Adults can have febrile seizures, but more often than not, we're talking about toddlers. And then if your protocol allows for some acetaminophen or ibuprofen or something, an antipyretic, a fever lowering medication, then that would make some sense as well. So anyway, seizures, fairly common. Typically a known cause. They have a seizure disorder and they quit taking their meds, but the uncommon things are where we become very valuable. Eclamptic seizures, that needs to have the pregnancy resolved. And then febrile seizures, we need to cool them and watch out for that status epilepticus, a very long, one single seizure lasting more than 5 minutes, or back-to-back seizures without a return to normalcy. So that's pretty much the down and dirty what you need to know on seizures. In your resource document, there's a link to some further study if you would like. But that's the end of this lesson.